Right, yeah, good afternoon, everybody. It's a great pleasure to be here. So as you can tell, there's going to be two parts to this talk. In my part, I'd just like to cover how some of the areas that Illumina is sort of supporting the newborn screening community. And then I'll pass over to Zeb, who's going to tell us more about how his program and some of the things that he's been doing with us in the collaboration. So if you just start off, I was thinking, put this slide together. And there's quite a wide range of things that Illumina gets up to in this area. It's a fascinating and growing area very much. I think to start with, one of the things we're really involved with is in consortia and collaborations. We're very keen to support pilots and help evidence generation to help move the field forward. And you heard some of these, some of the sort of public groups that we've been involved with this morning with sort of the early check work, which got announced very recently. It was so recent that I didn't have time to put it on this slide. But also working with the Guardian group and Screen for Care. Just call out a couple of other things here. We're also working with the Beginnings group. This is more of a pre-competitive consortium of several different companies, just bringing technologies and thoughts together to move everything forward. And I think you'll hear more about that in the next couple of days. And then with say Screen for Care and the Iridic group as well. These are more sort of projects and programs, sort of national, multinational programs that are trying to push forward sort of early diagnosis via genomics. And I just point to a nice paper that's just come out from the Iridic group, which is a summary of a lot of the work that's going on in Europe. And then just another group there with the Netherlands as well, the Spring group that is doing some very interesting work that we're helping with. One other area, or other areas that we're involved with, we have a small but very strong patient advocacy group. We want, as a company, to bring things in from the outside, for the societal impact that all this has, but also to have a voice, being part of industry in the discussions that are going on. Wide range of things, societal impact, but also, as Robert was saying this morning, about actionability. What does that mean to a clinician, and what does that mean to a patient or to a patient's family? We run a variety of advisory boards around the world, where we get sort of thought leaders in to discuss this whole area and just bring thoughts together and try and generate discussion and consensus. And we also have a sort of gene curation group, so we're sort of contributing in that way as well. And then more in my area, really, which is around sort of R&D and what we're trying to do. Illumina as a company, we're known as a sequencing company, but really we're trying to move more towards a solution-based company. And so we're very keen to get involved in a lot of these early stage projects to see how we can help develop our tools to fit with the needs of this new area, which are quite different to some of the other areas that we're traditionally involved with. So we're putting workflows together. We're developing our analysis tools and pushing all that forward, and you'll hear more from Seb in a minute with the Baby Screen Plus project. Just a couple of things on some of the tools. The short read data is obviously very good, very high quality. There are certain areas which are less clear, but we do have, with our sort of secondary analysis tool, Dragon, we can target particular genes, those which are a bit more challenging. We have a list that we've worked through so far. We're always keen to hear about other genes of interest where we can sort of tailor our callers to be more accurate. SMN came up, so we do have a caller there, and we're sort of working on further improvements for it. On the long read side, we announced earlier in the year our sort of long read technology for whole genomes. Later this year, we'll come out with an enrichment version of this. So this is filling in some of the gaps using a panel. We'll come out with a sort of standard panel to start with, but next year we'll come out with the ability to do custom panels. So if there are certain areas that you want to cover that are of particular interest to you, you're able to generate those panels as well. So on the workflow side, it's when you look at things, samples come in, they get go through accessioning. You need things all the way through to automate, to make library preps, to scale, to do sequencing, and then go through to secondary and then tertiary analysis with a report at the back end. And we're trying to put all of this together to make it seamless. So, you know, it's not always straightforward, but we think we have the tools, and as we work with more people, we'll make this more of a, you know, just a package that people can use to save people sort of reinventing stuff, which really, you know, the provider should be able to do this all in one go. You know, we've got some experience of this with, we do a lot of like population scale sequencing, you know, getting towards, you know, the hundreds of thousands, the 1 to 2 million sort of population scale. So we know a bit about the scaling side, but not in this area. That's different, and there's things to learn. So we definitely want to be able to help there. And then I'll just zoom in a little bit on the tertiary side. So yeah, we have our sort of package called Imagine. So this ingests data into Dragon. We have we use AI in there, but it's called explainable AI, so that when you come up with a prioritized list of variants, you can then sort of get a report out of that. And you know, the goal is to come up with an automated report, so there's no sort of human intervention, you know, for the negatives. But I will let Seb talk more about that.
Thanks, Kevin. And yeah, so this is really continuing the dive into the actual application. Quick introduction on Baby Screen Plus, so I won't go into too much detail because Lil will give the product update tomorrow. But we, compared to some of the other things that are going on, a smaller study with the aim to sequence 1,000 Victorian newborns by whole genome sequencing, and we're screening for, at latest count, over 560 treatable conditions. One of the things we really try to do, because we're working out of a clinically accredited environment, is to immediately go live with a test that is clinically accredited and directly usable in our medical system. So we designed a study that really tried to achieve that and focus primarily on the feasibility and acceptability of the overall screening approach. So we really made a point of not just going into the lab bits, but really look at the overall experience and the integration into the healthcare system. But alas, this session is about the lab bits, and I'm the co-lead of the study. I'm also the resident study nerd. And today we will really focus on one of the core aspects that is needed to deliver this at scale, and that is the automation and analysis of the results. And in particular, we have focused on the automation of negative results, because, I mean, 98% of results in the screening space are expected to be negative. So if we can get those out the door quickly without human intervention, then we're saving a lot of manpower and people power to actually get that project out the line. And we chose imaging for this particular application, not because it's the longest tool in the market, and not even because we're using it currently diagnostically, but because it has a lot of capacity to integrate into other systems. The APIs are excellent, and that's something that we really valued for our automation approaches. So we really try to design a system that minimizes interaction with low chance cases, where we can put them on the sequencer and ideally get the report out of the other end without anybody ever looking at it, while maintaining high sensitivity of the results. And we ended up designing a system of combination of imaging and some of our localized solutions, where in essence it allows us, once the data comes off the sequencer, then the Dragon pipelines and the imaging systems provide the filtering. And we've built API modules that can then iterate the data and automatically make a decision whether there's anything of interest in the data. And if the answer to that is no, that will automatically go into our reporting system and automatically go out into the study reporting tool. Or it would if diagnostic types aren't paranoid. So we've got a little check just in the end, but that we will probably eventually turn off. Just for context, so what constitutes a variant of interest for us is really based on what we look into and find in the external data and internal databases. And we're looking at a lot of the standard stuff we've already discussed: high impact variants, loss of function, mode of inheritance. So in the first instance, there's nothing really special about this. This is just about building an algorithm about the things we already know. This is just about building the basics, and we wanted to see how far this will get us. And to my actually pleasant surprise, it did quite well in the first iteration. So in terms of sensitivity, 98% of the cases we put through as known cases we actually picked up, and the one we missed was a multinucleotide variant, which is a known issue in imaging that's about to be fixed in the next version or in the version after. So that's about up and coming. But more interestingly for us, of the known low chance cases, already 73% went through without any human intervention. So that was the purpose of the automation. I was hoping to get 30 or 40% in the first instance, so I was really quite happy to get to that stage. More importantly, we learned a lot about the additional variants that we wouldn't normally consider about a variant of interest and how we can take that next step to push these numbers to 80, 90% plus, hopefully, in the future. And a lot of that is simple. Quality of variants, especially in the CNV space, where the databases are not as good yet, will give us an additional huge boost. And then cleaning up unreliable data matches in the literature and in ClinVar and other databases will again give us an additional increase. Interestingly enough, and somewhat to my surprise, variants that are in cis only made about just under 2% of the overall issues. So that wasn't as much of an issue in the recessive space as I thought it would be. Nothing is like real-life data, so we're also up and running for the 2 months now. We've already recruited 10% of the cohort, so it's going very quickly. Fortunately, the validation data panned out in real life. Out of the almost 30 cases, still 56% go through as AutoNext, so we really got a solid foundation to build on. And really, more interestingly, as code outcome, we've actually got a reasonably good level of automation. We've got many ideas for further improvements, and our pipeline is clinically accredited and deployed in a clinical setting, so every report that actually comes through the system is immediately used in the healthcare system, although we haven't had a high chance result yet, which is probably not surprising considering the low numbers. So with that, before we get in further trouble, I'll thank the crew, especially my colleague Zonica and obviously Lil. Big shout out to the imaging team that helped us in really just over 4 months build a pipeline that we could use in a clinical setting. Kristen is in the audience. Thank you to you, and thanks to you for listening.